All right. So continuing on with cancers of the male reproductive system. Let's talk about prostate cancer. This gets a little bit complex. There's been a lot of different studies and evidence and lots of stuff about this. So bear with me. We'll go over it in class 2. Promise. Okie dokie. So prostate cancer is staged this way. So there is like the stage based on the tumor. Let me grab my pen. There is the stage based on the tumor. And then we also, and the stage is also based on that lymph node involvement and on metastasis. So all of this kind of goes together. There's also the PSA levels that are taken. And then there's also a Gleason score. Okay, what the heck is a Gleason score? A Gleason score is based on the Gleason scale. Gleason was a busy person. He developed a bunch of stuff. So what the Gleason scale does is it's used by the lab on that biopsy to look at the differentiation between the prostate cells that would normally be thinking of prostate cells all the way up to these don't look like prostate cells at all, even though we know they came from the prostate. So grade 1 is that they look the most like the original cells. A grade 5 is they don't look very much at all like the original, like prostate cells should look like. And then what happens is when people are being evaluated for prostate cancer, they actually will do like multiple slides and look at them under the microscope. So multiple samples, multiple slides are evaluated. Then they come back and they take a look at the 2 most common cell patterns. Those are added together, and that's how they get the score. So they'll put together like 10 or 15 histology slides. They will find the 2 most common patterns out of that 10 or 15 slides. And then they will add those scores together to get the Gleason score. So a Gleason score of less than 6 is associated with very low risk, all the way up to a Gleason score of grade 9 or 10. They do have grade groups associated with this as well. So just to let you know, I'm going to hop back to the previous slide. This Gleason score business is specific to prostate cancer. We don't really use, not to my knowledge, we don't use the Gleason score anywhere else when it comes to cancer. Otherwise, I would have talked about it in chapter 15 slides. So moving through. So prostate cancer management is, they can be in active surveillance. Active surveillance is where we're closely monitoring that PSA and the digital rectal examination at least once a year, maybe every 6 months, maybe even every 3, depending upon what's going on. There is repeat prostate biopsies, repeat imaging. There may be genomic testing on that biopsy tissue if it's appropriate. Some different prostate cancers are genetic in nature. After we get into active surveillance, moving on from active surveillance, let's say for whatever reason we have to move on from that, we can go to surgery. We can go to surgery and or drug therapy, and we go to radiation therapy. All of these can be in combination with one another. So get my arrows straight here, or not straight, but at least appropriate. So for surgery, you could have a radical prostatectomy where they take the entire thing out surgically with an abdominal incision, or they may go through the urethra like they do for BPH. You can have cryotherapy. Cryotherapy is cold therapy, and that cold therapy destroys the tissue. You can have orchiectomy. Orchiectomy for metastatic disease. If there is a person who has prostate problem or prostate cancer and it's spread to the testicles, they will have an orchiectomy as well. Radiation therapy, you can use external beam for primary, recurrent or adjuvant disease. You can also use brachytherapy, which are these little radioactive seeds that are about the size of flax seeds, or maybe those of you who are health conscious people, maybe you have chia seeds that you add to different things. They're that small, and they're they're just full of radioactive isotopes. And then through needle insertion, they get implanted into that diseased prostate. It's wild. Anyway, and then there's also drug therapy. So androgen deprivation therapy, because prostate cancer thrives on testosterone, we may do some androgen deprivation therapy. See table 54-7 in your book. And then there may also be chemotherapy for any sort of metastatic disease. And let's go into nursing management. And I'm just going to keep trucking through here. So for nursing management, regardless of, I shouldn't say regardless, for nursing management for prostate cancer, there we go, is we're going to be, since you're going to see that there is a lot of different stuff here, and it all looks like BPH. So if you go back to the BPH slide, I could just copy paste. If I could snip, I could just snip what I recorded in BPH and put it over here. We need to see if they're on testosterone supplements. The prostate really does grow because of testosterone supplements. All of these other sorts of urinary problems are all associated with BPH as well. So in the interest of time, I'm just going to keep it moving. So diagnoses, we're going to be working with people for nursing diagnoses with lack of knowledge, acute pain, urinary system or urinary retention, impaired urinary system function, impaired sexual functioning, and anxiety, as well as there's a risk for infection, but that risk is usually not what we're educating them on when it comes to prostate cancer. Usually we're educating them on these 5 things. Our plan is going to be including them being an active participant in the treatment plan, having acceptable pain control, following the therapeutic plan, understanding the effect of therapeutic plan on sexual function, and finding an acceptable way to manage the impact on bowel and bladder function. So this treatment for this involves a lot of different work between the hip joints, and that is going to be impacting their bowel function as well as their bladder function. So if we can find acceptable ways to manage the impact, we're going to have a much higher incidence rate of following the therapeutic plan, and that acceptable ways usually involves them being an active participant as well, and it helps them own the process. Implementation. So regular prostate screenings after the age of 45. This can include a few different things. It can include drawing a PSA. There is some evidence in the world right now where drawing a PSA might not be as advantageous as what we think it is. The cost benefit versus benefit isn't as good as it should be. Current evidence is leaning towards, let's just do a really good assessment on their urinary elimination and see if we even need to draw blood. So depending upon what sort of protocols and what sort of evidence your facility is using, it could be those prostate screenings could come in one of 2 different ways. It could be coming from a really solid elimination, urinary elimination. It could be coming from a PSA draw. It could be a combination of both. In acute care, we're going to be providing sensitive caring support for the client, and we're going to be using a lot of the same techniques that I talked about in BPH. For ambulatory care, we're also going to be using a lot of the same techniques as BPH. If the cancer has metastasized, the client may also benefit from like palliative care, all the way up to hospice care. And the reason why I say it that way is palliative care is not hospice. Hospice is a part of palliative care, but palliative care is all about pain management and quality of life. So you don't necessarily need to have hospice care to be able to get palliative care. And for those people who have had metastases to the spine, what happens typically when you have metastasis to the spine is it is incredibly painful. They can lose cranial nerve function, and they can use and they can push on their sensory nerves as well. So the sensory nerves are going to cause pain, but impacting those cranial nerves, you may have people who are losing sight, who are losing hearing, who are losing the ability to swallow. Like, think of all those cranial nerves that you studied last semester. And if you had a tumor in your spine pushing on them, it could create very, very big problems. Or not even in your spine. If you had a brain tumor pushing on them, it would cause very big problems too. So evaluation of this is, are they actively participating in the treatment plan? Do they report acceptable pain control? Are they able to follow the therapeutic plan? Do they understand the effect of the treatment on sexual function? And do they understand not necessarily only the effect, but the why behind it? And that it's not a dig on their ability to be sexually active. This isn't like an insult to them. This isn't something that should be, they'll get really emotional about sexual function. They really will. And so this isn't 100%, this is depending upon how everything is going. This could be a temporary just moment in time in the big scheme of things, but it can be the treatment on the impact of treatment on their sexual function is huge in terms of self-esteem and self-perception. And then finding an acceptable way to manage their impact on, or manage the treatment's impact on bowel and bladder function. People who have a lot of inflammation from, we don't need to go to case studies. So people who have a lot of inflammation and who have a lot of impact in treatment on that pelvic girdle area are going to be having a lot of impact on their bowel function as well. So that is the end of my slides for content. There are case studies that are a part of this from slide 45 through the end. I think I've got like 54 slides. So to help you process the information better. And I will see you in class.